Hello everybody. Today we are going to discuss about plasmapheresis. So first we will understand what apheresis and plasmapheresis mean. Apheresis is extracorporeal blood purification where one constituent is removed and the remainder is returned to the patient. That means the substance which we want to remove, we are removing that only. But then what is plasmapheresis? Plasmapheresis is the removal of the host plasma, which is replaced by donor plasma, colloid, or the blood products like albumin, FFP, cryo by either centrifugation or membrane filtration. So, what are the prerequisites for the successful apheresis? So, the prerequisites are substance must be present in the intravascular space. It should be large. It cannot be removed by ultrafiltration or high flux hemodialysis. Substance must have sufficiently long half-life. Endogenous clearance is either slow or ineffective but can be rapidly cleared by apheresis. There should not be any effective antidote or conventional treatment available for toxic substance to be removed. So substances which are successfully removed by plasmapheresis are immunoglobulin, immune complex, coagulation factors, cytokines, and endotoxins. Also, some protein-bound substance like drugs, toxicants, albumin, triglycerides, and other lipid, myeloma light chains, cryoglobulin, and autoantibodies. So there are some class 1 indication for plasmapheresis, that is GBS, HUS, hemolytic uremic syndrome, thrombocytopenic purpura, good pasture syndrome, Viper viscosity syndrome due to myoclonal gammopathies, acute liver failure, myasthenia gravis, CIDP, and renal transplantation to desensitize or manage antibody mediated rejection. Other indications are sickle cell crisis, cryoglobulinemia, paraproteinemic polyneuropathies, Waldenstrom macroglobulinemia, systemic vasculitis with pulmonary hemorrhage, hemophilia due to anti-factor 8 inhibitors, antiphospholipid antibody syndrome, autoimmune hemolytic anemia, immune complex glomerulonephritis, systemic lupus erythematosus, systemic vasculitis. Then thyroid storm, Amanita phalloid toxin, familiar hypercholesteremia and hypertriglyceridemia, and some toxins like paraquat, digoxin, and envonation. And other indications are HELLP syndrome, multiple sclerosis, HIV neuropathy, and pemphigus. Paraneoplastic syndrome, DIC, overwhelming sepsis syndrome like cytokine filters, and Rayet syndrome. Now we'll talk about practical aspects. So, as far as removal is concerned, we should remove at least 1 to 1.5 times of the plasma volume. Now, how are we supposed to calculate this plasma volume? So, plasma volume is equal to 0.07 into body weight into 1 minus hematocrit. So, this plasma volume should be removed either daily or alternate day. So single volume plasma exchange will reduce the concentration of immunoglobulin, complement protein, fibrinogen, and other coagulation factor by 50 to 60% if the plasma is not replaced. Most constitute will return to normal level within 24 to 48 hours. Antibodies may be rapidly resynthesized during immune response, so the clinical impact of plasmapheresis may be slower than the anticipated. Now about replacement, 5% albumin, FFP, and cryoprecipitate are typically used as replacement fluid. First 1 to 2 cycles may be done with albumin replacement, but further cycles may cryo. Replacement fluid is given concurrently to maintain hemodynamic stability. Ideal to replace with 5% albumin or 20% human albumin, which may be diluted in 400 ml of NS to produce 500 ml of 5% albumin. So we'll see what is the difference between 5% albumin and 20% albumin. So usually 5% albumin is indicated in volume replacement in hypovolemia. Large volume will be needed for volume expansion. It is isotonic to plasma and it contains 130 to 160 m equivalent of the sodium. Now about 20% albumin. It is indicated in condition where fluid and the sodium restriction is needed. Even small volume can expand the blood volume significantly. It is hypertonic. It is named as low salt and salt-free albumin. So sometimes FFP can be used as replacement fluid if the patient receives daily or more cycles of plasma exchange. In case of TTP, HUS, pulmonary hemorrhage, and in patient with high bleeding risk. So calcium supplement is needed if more FFP is used for replacement, if citrate anticoagulation is used. Occasionally, magnesium replacement may be needed during citrate anticoagulation as citrate binds magnesium too. Give 10 ml of 10% calcium gluconate per liter of the replacement fluid. If you are planning to give this calcium. So points to remember whenever FFP we are using, we should keep eye on calcium and magnesium because this citrate can cause hypocalcemia as well as hypomagnesemia. Now about the anticoagulation, primary anticoagulants are citrate and heparin. The factors which are influencing the choice of anticoagulation is type of the plaques, patient's condition and bleeding risk, and history of pre-existing anticoagulation use. Now about the type of anticoagulation, regional citrate anticoagulation is generally preferred and most common method for the plaques, especially with the centrifugal device. So the citrate which it works by binding calcium ion, which is vital for coagulation casting. Citrate also has low risk of bleeding complication compared to heparin. Heparin is the preferred during membrane-based plaques where or when citrate is contraindicated. Heparin use is associated with high risk of bleeding complication than the citrate. So sometimes we are not using any anticoagulation where in some specific cases where the plex procedure might be performed without anticoagulation, which has been reported as a safe in single center study. So sometimes there is a high risk of the bleeding, or sometimes there are the condition when we cannot use citrate as well as heparin. So we can proceed ahead with no anticoagulation strategy. Now about the management of anticoagulate patient. If the patient is already on systemic anticoagulation, that is warfarin, direct oral anticoagulant, or heparin, Plex introduces additional complexities and unpredictable impact on coagulation parameters. Now about individualized approach. Management requires individualized approach considering patient's overall clinical condition, bleeding risk, type, and pharmacokinetic of anticoagulant medication. Now about monitoring, close monitoring of coagulation parameter like fibrinogen level, anti-10 activity, INR and APTT is crucial before, during and after the procedure. Now about the dose adjustment, anticoagulant dosage may need adjustment or temporary cessation around plaque section as the procedure itself removes circulating coagulation factor and anticoagulant drug from the bloodstream. So plaques can significantly alter anti-factor 10A activity of molecular weight heparin, which is requiring dose adjustment. So about reversal agent, in case of severe bleeding or urgent need for invasive procedure, plaques itself can be used to reverse the effect of some anticoagulants like apixaban. Now, what are the things that we need to monitor during plaques? So daily INR, PT INR, APTT, serum potassium, calcium, CBC with platelet count. Now about adverse effect, there are some complications of vascular access, hypocalcemia, hypovolemia, hypotension, vasovagal complication, mechanical hemolysis, transfusion reactions like TRALI, TACO, dilutional coagulopathies, inadherent drug removal, hypothermia, hepatitis, electrolyte imbalance, suxamethonium apnea, infections, and hypoproteinemia. Thank you, guys.